Yeah, slides are perfectly visible.
And they are moving also?
Yeah, they are moving also. They are moving also.
So, thank you, Dr. Pawan, and thank you, IMA, Dr. Mahavir, Dr. Dhirender Soni, for such a nice initiative. And we would like to discuss this very important topic today. And you all know that a lot of media attention has been there that many young people are dying. There's a sudden cardiac death, and it has been highlighted in the media also. There is a lot of panic among public also. People do come to our OPD and ask about this thing. So we'll try to decipher what actually it is and what we can do to prevent it, and maybe what we can do if we see somebody having collapse, or having sudden cardiac death. So I'll just like to draw to your attention to this ECG. Let us see, we find this ECG, and if I tell you that this is a guy who had got this ECG done around 3 days back and now he has suddenly died, so what will be in your mind? So just keep in mind this ECG, and then we will try to find out what actually we want to we need to know about the prevention of sudden cardiac death, and also what we can do to prevent this. So what is the definition of sudden cardiac death? So it is the natural death from cardiac causes heralded by abrupt loss of consciousness within 1 hour of the onset of acute change in cardiovascular status. Every death is not sudden cardiac death, it is sudden death. But the sudden, if the definition says that if the patient was previously known to be healthy and he has died within 1 hour of somebody has seen him healthy or he was absolutely fine, then it is presumed sudden cardiac death. We all know it is a silent killer, just comes like a bolt from the blue. एकदम से आता है, लोग कहते हैं अभी तो बात कर रहे थे, अभी नहीं मिले. So there have been a lot of media attention. Wasim Raja, famous Pakistani cricketer, died. Then Nair Hospital Dean died. A very young director, Manoj Punj, at 36. And there are so many media reports of young people dying in gyms and absolutely healthy. So what to talk of older people, young fit footballers dying of cardiac arrest on the field. So what actually is the incidence? So the incidence overall is very high, around 3 lakh cases per year. So that is a huge number. But I would like to draw your attention to the fact that every sudden cardiac death is not myocardial infarction. इस तरह से प्रेजेंट किया जाता है कि उसको हार्ट अटैक से डेथ हो गई, हार्ट अटैक से डेथ होगी. सो व्हाट इज द डिफरेंस? सो व्हाट एक्चुअली is what do you mean by myocardial infarction and what do you mean by sudden cardiac death? So heart attack हम सबको मालूम है, it is because of the blockage in the coronary artery. It prevents blood flow. Lack of blood causes damage to the heart muscle and scar tissue. It can cause sudden cardiac death because the blockage of artery to the blood heart muscle can lead to arrhythmia, which can lead to sudden cardiac death. So every sudden cardiac death is not heart attack, but a heart attack can cause sudden cardiac death. So what is cardiac arrest? Cardiac arrest is abrupt cessation of cardiac activity without warning, and if it is not electrically shocked, the death occurs within minutes. It can happen to previously normal heart, seemingly normal heart, which has a genetic heart condition, or it can happen to previously damaged heart, जिसको कई MI और heart attacks पहले हो चुके हैं. So these are not synonymous, but we need to know this difference. So what are the symptoms of sudden cardiac arrest? You know, often it occurs without any warning or symptoms. It is immediate, drastic, sudden collapse, no pulse, no breathing, loss of consciousness. But there are preceding symptoms sometimes, like a fatigue, fainting, blackouts, dizziness, chest pain, but these are very non-specific symptoms, and usually we do not associate with that these must be the cause of having sudden cardiac death in a patient who had previously complained 2-3 days ago or few weeks ago about these symptoms. So, but whatever it is, it's a fatal thing. The life slips away every minute. If not intervened within 10 minutes, sudden cardiac arrest can be fatal. तो आज जो हम डिस्कस करना चाहेंगे वो ये है कि हमने सडन कार्डियक डेथ को सिनोनिमस बना दिया है हार्ट अटैक से. मीडिया हैज आल्सो प्रोपेगेटेड दिस आइडिया. इन ओल्डर पेशेंट्स द 80% of the substrate of sudden cardiac death is coronary artery disease. 15% is cardiomyopathy and 5% are other, the ion channel abnormalities, valvular or congenital disease and other causes. So can I request everyone to be on mute mode, please? Please. So आज हम जो कंसंट्रेट करेंगे ये रेस्ट 20% पे करेंगे, क्योंकि डॉक्टर पवन गोयल ने हमें कहा है कि टू टॉक अबाउट सडन कार्डियक डेथ इन यंग पेशेंट्स. नाउ लेट अस सी what is the incidence of these causes in young patients? So this is a very important data from the Minneapolis Heart Institute Foundation. Now you see these are around 300 athletes dying of sudden cardiac death. So let's look at the causes. The most common cause is hypertrophic cardiomyopathy. Then there is commotio cordis. And if you go down, it is ARVD, ruptured aortic aneurysm, and atherosclerotic coronary artery disease is only 2.6%. So atherosclerotic coronary artery disease, जिसको हम सब एसोसिएट करते हैं हार्ट अटैक से, हम कहते हैं हार्ट अटैक से डेथ हो गई, यंग एथलीट्स में जो डेटा एक हमारे पास है उसमें जस्ट 2.6% इज द कॉज एट्रीब्यूटेड एज एथरोस्क्लेरोटिक कोरोनरी आर्टरी डिजीज फॉर सडन डेथ. Similarly, now this was the recruits, military recruits, seemingly healthy recruits dying during training. In this also you can see the most common cause is myocarditis, hypertrophic cardiomyopathy, atherosclerotic coronary artery disease, only 10 deaths because of this. So basically what I mean to say is in young patients में arrhythmia ज़्यादा important cause है, और channelopathies, congenital conditions वो हैं, उनको आज हम थोड़ा डिस्कस करेंगे. Most likely the cause is arrhythmia. So what is arrhythmia? Now you can see a normal heart beating, and if you can see this video carefully, so this is normal heart, and then it is ventricular tachycardia. Ventricular tachycardia में क्या होता है? The heart starts beating very fast. There is no effective contraction, and the brain doesn't get the blood supply. So, and this is ventricular fibrillation. So this is like, totally irregular heart, no effective contraction, almost fatal if not intervened within a few seconds by electrical shock. So what are these causes? ये channelopathies, ये hypertrophic cardiomyopathies क्या हैं? So these are the list of causes. This is not exhaustive list. There must be some other also, but these are the most common. So the long QT and short QT syndromes, the Brugada syndrome, hypertrophic cardiomyopathy, ARVD, arrhythmogenic right ventricular dysplasia, commotio cordis, and coronary anomalies. So why I am discussing and emphasizing on this is that because as physicians, as doctors, as healthcare providers, we should be aware that these are the causes which are the most important in causing sudden cardiac death in young athletes, young fit athletes, जिसके बारे में आजकल इतना ज्यादा हो रहा है कि जिम में डेथ हो गई, एक्सरसाइज करते हुए डेथ हो गई, वाज एब्सोल्युटली नॉर्मल, बैडमिंटन खेलते हुए डेथ हो गई. So these are the causes. Until unless we open our eyes to these causes, we know these causes, we will not look for them, and if we do not look for them, then obviously we cannot prevent them, treat them. उसके बारे में भी we will talk about how to prevent and treat them. So long QT syndrome क्या होता है? It's a genetic condition, autosomal dominant, autosomal recessive. Total ये सात तरह का होता है. I would not go into the details of the specifics of it because these are specialized cardiology topics. So what we need to know is that we can easily diagnose on ECG that the patient is having long QT syndrome. Until unless we look for it, we cannot do it. So ये basically channelopathies होती हैं. हम थोड़ा सा मैं आपको अपना MBBS का लेवल का याद करा दूं that there is movement of the ions, sodium and potassium ions, for ventricular depolarization and repolarization. So what happens in long QT syndrome is these movement of the ions is delayed and ventricular depolarization is prolonged. थोड़ा सा हम याद करें, ईसीजी में क्यू वेव पी वेव होती है और फिर क्यूआरएस है एंड देन टी वेव है. क्यू से लेके टी तक वेंट्रिकुलर डीपोलराइजेशन है, टी वेव वेंट्रिकुलर रीपोलराइजेशन की वेव है. सो ये डीपोलराइजेशन अगर प्रोलॉन्ग्ड हो जाए ड्यू टू स्लो मूवमेंट ऑफ आयंस अक्रॉस द एपिकार्डियम टू एंडोकार्डियम तो लॉन्ग क्यूटी हो जाता है. अब ये ईसीजी आप देखिए, जस्ट सी दिस ईसीजी, सीमिंगली इट लुक्स लाइक एब्सोल्युटली नॉर्मल ईसीजी, बट हमें अगर ध्यान से देखें तो इसमें क्यूटी इंटरवल प्रोलॉन्ग्ड है. क्यूटी इंटरवल हमें लेना है यहाँ क्यू से लेके स्टार्ट ऑफ क्यू अप टू द एंड ऑफ टी. अगर कोई यू वेव है तो वो भी इसमें इंक्लूड करनी है. एंड दीज आर द नॉर्मल वैल्यू. सो इफ इट इज मोर देन 470 milliseconds in women it is more, and it is more than 450 milliseconds it is men. जब हार्ट रेट फास्ट हो जाती है तो लॉन्ग क्यूटी भी शॉर्ट लगने लगता है. तो इसलिए एक वर्ड आया क्यूटीसी विच इज नोन एज QT corrected. उसके कुछ फॉर्मूले हैं, but most of the normal modern ECG machines they themselves calculate the QTC and give a value written on the top of the ECG interpretation. अब आपको एक जर्नल, I will give you a tip how to diagnose QTC लॉन्ग क्यूटीसी जस्ट लाइक दैट. सो जस्ट लुक एट द आर इंटरवल. अगर आप ये देखो कि जो टी वेव है इट इज हाफ और मोर देन हाफ में आ रही है इसके, तो ये मोस्ट लाइकली लॉन्ग क्यूटी सिंड्रोम है. क्लियर है सबको? कितना सिंपल है इसको जानना. हमने आर को देखा, ये टी वेव इसके हाफ या हाफ से इधर आ रही है, नॉर्मली यहाँ पे होती है टी वेव. अगर हाफ या इधर से हाफ से इधर आ रही है तो इट इज मोस्ट लाइकली ये लॉन्ग क्यूटी ईसीजी. जब हम उसकी जेनेटिक टेस्टिंग कर लेते हैं तो वो लॉन्ग क्यूटी सिंड्रोम बन जाता है, और अगर सिम्टम्स हो, सीजर हो, सिंकोप हो, तो इट इज ए फुल फॉर्म ऑफ लॉन्ग क्यूटी सिंड्रोम. तीन तरह के लॉन्ग क्यूटी सिंड्रोम हम यहाँ डिस्कस कर सकते हैं, बट आई डोंट थिंक इट्स रिक्वायर्ड. सो दीज आर द फॉर्मूलाज बाय विच वी कैन करेक्टेड लॉन्ग क्यूटी हम ले सकते हैं. वेरी सिंपल टू डायग्नोज ऑन ईसीजी. many medicines and acquired metabolic disorders can also cause long QT syndrome. How to diagnose it? ये short scoring है, इसमें QTC देख सकते हैं, and it predisposes the patient to a very fatal kind of ventricular arrhythmia which is known as torsades-de-Pointes. It is, and if that is present, if there is a history of syncope, if there is a family history, so इस सब की scoring हम करके, if it is more than 4, then we can say, you can see at the bottom, it is a definitive long QT syndrome. So ये एक तरह का चैनलोपैथी है जो सडन कार्डिक डेथ का कॉज कर सकती है. देखिए कितना सिंपल इसमें रिकमेंडेशन है कि अगर हम जेनेटिक टेस्टिंग से वी डायग्नोज दैट द पेशेंट इज हैविंग लॉन्ग क्यूटी सिंड्रोम, देन नो पार्टिसिपेशन इन कॉम्पिटिटिव स्पोर्ट्स. एंड फॉर दोज पेशेंट्स हु हैव लॉन्ग क्यूटी, बीटा ब्लॉकर्स आर सफिशिएंट. इसके बाद भी अगर if somebody is having syncope on receiving beta blockers, or for the survivors of cardiac arrest, so very easily we can treat them by putting an implantable cardioverter defibrillator. ये हम क्या होता है, it is, we will discuss it. It is like carrying a cardiologist along with you in your chest. ये diagnose करेगा ECG और खुद से शॉक दे देगा. We will discuss that also. सेकंड है ब्रुगाडा सिंड्रोम. एक बहुत ही फेमस कार्डिक सर्जन हैं, उनके वेरी नियर फैमिली मेंबर को ब्रुगाडा सिंड्रोम डायग्नोज हुआ. ही इज विद नाउ आईसीडी एंड ही इज सेफ. सो दिस इज नॉट अनकॉमन टू हैव. सो इस ये भी चैनलोपैथी है, बिकॉज देयर इज, इसकी दो थ्योरीज हैं, रीपोलराइजेशन डिसऑर्डर एंड डीपोलराइजेशन डिसऑर्डर. दैट आई डोंट थिंक वी नीड टू डिस्कस दैट. बट हाउ डू यू फाइंड ऑन ईसीजी? लुक एट द ईसीजी, दीज आर फनी लुकिंग ईसीजीज. इस तरह से एक एसटी डिप्रेशन है. I just want many ECGs इसलिए रखी. I want all of you to have a look, and if you find such kind of ECG, don't dismiss it as an artifact. At least have a specialist opinion that there is something funny, and I will also enumerate how to diagnose it and how we can suspect that somebody is having such kind of channelopathies. अगर किसी patients में there are some medicines which can be given like calcium channel blocker, beta blocker, simple, and they can unmask the Brugada syndrome in a patient in which the ECG is not very suggestive of Brugada syndrome, but we suspect it. So these are the diagnostic patterns. Just there is no, we can find out with the ECG, and then what is the treatment? Simple, ICD. If the patient has a previous cardiac arrest, survivor, ICD. Previous syncope, class 2 indication for ICD. But there are medicines also like quinidine which can be given orally and can suppress the incidence of ventricular arrhythmias, fatal ventricular arrhythmias in such patients. So ये दो तरह की channelopathies हमने discuss की, which are very easily can be diagnosed on ECG, but we need to know about them to look for them, and then we need to know what to be done for them. That is not everybody's cup of tea. At least if we know that, we can refer him to a specialist and have an opinion, and probably a young life can be saved. Now, a very important thing is hypertrophic cardiomyopathy. We have seen in the slide from the Minneapolis that the most common cause of death in young athletes was hypertrophic cardiomyopathy. ये basically एक defect है myocardial contractile proteins में. उससे हार्ट का मसल बहुत ज्यादा थिक हो जाता है. ये मायोकार्डियल कॉन्ट्रैक्टाइल प्रोटीन्स हैं. वी ऑल नो ट्रोपोनिन आई, ट्रोपोनिन टी, अल्फा ट्रोपोमाइसिन. सो द सार्कोमियर स्टार्ट लुकिंग लाइक दिस, एंड ये बड़ी इंपॉर्टेंट स्लाइड है टू अंडरस्टैंड. सी जो टॉप में है वो नॉर्मल एलवी है, इस तरह का नॉर्मल एलवी होता है. बट दिस यू नो इज ग्रॉसली थिकन्ड. एसिमेट्रिकल थिकनिंग हो सकती है, सिमेट्रिकल थिकनिंग हो सकती है, एंड देन बहुत ज्यादा जब थिक हो जाता है मायोकार्डियम, तो व्हेन इट कॉन्ट्रैक्ट्स सो दे मीट इन बिटवीन. तो इससे क्या होता है, ऑब्स्ट्रक्शन पैदा होगी लेफ्ट वेंट्रिकुलर आउटफ्लो ट्रैक्ट में. हार्ट ने यहाँ कॉन्ट्रैक्ट करना था, ब्लड को एओर्टा में भेजना था, यहाँ पे ऑब्स्ट्रक्शन होगी. सो देयर इज ए ग्रेडियंट, वो बन गया. एंड नाउ हाउ टू डायग्नोज इट? वेरी सिंपल. फर्स्ट ईसीजी जो मैंने आपको दिखाई थी वो हाइपरट्रॉफिक कार्डियोमायोपैथी की थी. and an echo can very simply within 5 minutes can diagnose that patient is having hypertrophic cardiomyopathy or not. So it can straight away present like sudden cardiac death, but the patient may give you symptoms of syncope, heart failure, chest pain, palpitation, and there is a murmur also, which has very characteristic findings that it decreases with squatting and increases with standing. So ये आजकल स्टेथो बहुत कम लोग यूज करते हैं और क्लिनिकल एग्जामिनेशन डिक्रीज होता जा रहा है, बट इको कैन डायग्नोज विद इन ए मिनट इफ वी सस्पेक्ट इट एंड ईसीजी शोज एलवीए. सो दिस वाज द ईसीजी. नाउ कोई भी इसको देखेगा वो एमआई कह सकता है कि पेशेंट को एमआई हो गया, हार्ट अटैक हो गया, बट दिस इज ए क्लासिक ईसीजी ऑफ LVH induced by hypertrophic cardiomyopathy. So अब एथलीट्स हार्ट जो होते हैं, जो बहुत विगरस ट्रेनिंग करते हैं, या दोज हु आर बॉडी बिल्डर्स, रेसलर्स, boxers, they can have also hypertrophy of the heart. So we need to differentiate between hypertrophic cardiomyopathy and athlete's heart. So usually athlete's heart, the thickening is not more than 16 mm. In hypertrophic cardiomyopathy, it can be more than 16 mm, and the LA size is enlarged, very high QRS voltages, impaired relaxation, and family history is usually present in hypertrophic cardiomyopathy, where all of this is not present in athlete's heart. And another thing which is very important is that if we decondition an athlete, like he stops exercising, his LV thickness decreases over time, whereas in hypertrophic cardiomyopathy, this is not likely to happen. So the risk factor is very, very high. So the major risk factors are sustained VT, family history of premature death, and LV thickness greater or more than 30 mm. So if we find on ECG that the patient is having hypertrophic cardiomyopathy with left ventricular thickness more than 30 millimeter, we should immediately be alerted that this patient is very likely to have a sudden cardiac death. So, and treatment is very simple. We can give pharmacological treatment like beta blockers, disopyramide, maintain good hydration, verapamil. These all decrease arrhythmia. And we can ablate the hypertrophic myocardium also. We do this procedure very routinely. If it is, we find the cases, we can do it in our cath lab also. So this is one instance जब मैं लोगों को कहता हूँ कि normally कार्डियोलॉजिस्ट मायोकार्डियल इंफार्क्शन को बचाने में काम आते हैं, बट इसमें व्हेन वी डू द एब्लेशन ऑफ द एलवी मायोकार्डियम, वी एब्लेट द मायोकार्डियम. सो उसमें हम क्या करते हैं, हम एंजियोग्राफी से जाके वो आइडेंटिफाई द सेप्टल आर्टरी एंड पुट एब्सोल्यूट अल्कोहल इन दैट. सो दैट एरिया देन डाइज बिकॉज द मायोकार्डियम इज सो थिक. उसका कुछ पार्ट डेथ होता है, डाई हो जाता है, द थिकनेस डिक्रीजेस. इट डजंट अफेक्ट द पेशेंट एज हिज ऑब्स्ट्रक्शन इज रिलीव्ड and his symptoms of hypertrophic cardiomyopathy are relieved. Otherwise, we can always give an ICD if the patient is prone to arrhythmia. So these are very simple conditions and which are very frequently found. I mean, these are not rare conditions. The incidence, if we go to epidemiology, is very, very high. So we need to look for them, find out, and then guide our patients accordingly. इसी तरह की एक और कंडीशन है एरिथमोजेनिक राइट वेंट्रिकुलर डिस्प्लेजिया, जिसको ARVD कहते हैं. ये ऑटोसोमल डोमिनेंट भी है, ऑटोसोमल रिसेसिव भी है. सो इन दिस आल्सो द राइट वेंट्रिकल मायोकार्डियम इज रिप्लेस्ड बाय फाइब्रोफैटी टिश्यू. Patient may be asymptomatic, but he can complain of palpitation, syncope here and there. Usually these patients are dismissed as like having, some kind of stress, or maybe they are sent to psychiatrist. But if we do an echo, you can easily find that he is having arrhythmogenic right ventricular dysplasia, and this is also quite common. And most of the sudden cardiac death with ARVD is exercise associated because it increases the catecholamines. And there is on ECG, how can we find out? A very classical ECG, if we remember your MBBS days, epsilon wave. Just at the end of the QRS, you have a notching. Epsilon waves are seen, which are hallmark of ARVDs, arrhythmogenic right ventricular dysplasia. MRI is the gold standard for diagnosis because in echo sometimes you can have confusion, but MRI is the gold cardiac MRI. But the main point is that we need to know about this condition, and if we find some kind of funny ECG, we should like to investigate further. So these are the major and minor criteria of diagnosing ARVD, and history, ECG, epsilon waves. Biopsy usually nowadays it is not done, and echo or MRI can easily diagnose that there is some localized RV aneurysm, isolated RV dilatation, and the myocardium is replaced by fibrofatty tissues. So what does that tell us? That tells us that routine evaluation of an echo can, and ECG and echo can actually tell us about many of these fatal conditions, potentially fatal conditions. And if we diagnose them in time, then we can easily save the patient by putting in ICD or the appropriate medicines like amiodarone or sotalol in this case, which is only a class 2 indication. And we can, if there is a monomorphic ventricular tachycardia, then by electrophysiology and radio frequency ablation, we can ablate that. Although in ARVD, there are so many sources of ventricular tachycardia, so ablation is not very successful. Another thing is certain cardiac death because of low impact precordial trauma. आपने सुना होगा कि आर ऑन टी फिनोमिना होता है कि अगर हम किसी को मुक्का मार दें, छोटे से मुक्के से भी कोई आदमी मर सकता है अगर हम हार्ट के ऊपर मारें, बिकॉज अगर वो ईसीजी गेटिंग करके देखें और अगर वो हम उसकी टी वेव के ऊपर उसको इम्पैक्ट दे देते हैं तो ही कैन डाई. सो ये वी ऑल नो फ्रॉम आवर हिस्ट्री. सो दिस इज ऑल्सो एन इम्पॉर्टेंट कॉज कोमोशियो कॉर्डिस विच इज नोन. पूरा स्लाइड से चोट से हमें लगता है कि तो कुछ किया ही नहीं है, तो हार्ट अटैक से डेथ हुआ होगा. कई बार वी हैव हर्ड दैट somebody had died in custody because and the impact was not very high, torture बहुत कम किया गया था. So one of the causes of this is commotio cordis. Now another important and the last which we are going to discuss the case is congenital coronary artery anomalies. So in this what happens is जो coronary artery है वो pulmonary artery और aorta के बीच में से निकलती है. इसका भी incidence around 4 to 5% है. इसमें exertional death हो जाती है. Why it happens? Because the artery, the coronary artery is compressed between pulmonary artery and aorta. So patient presents with angina, chest pain, may have some syncope, dizziness, but can also present with sudden cardiac death. So the pathophysiology is that there is compression between the pulmonary artery and aorta, acute angle takeoff, which leads on to compression of coronary artery and myocardial necrosis, leading on to arrhythmia, leading on to sudden cardiac death. Again, echo I don't think is very good at diagnosing coronary artery anomaly. In children, only in babies we can do it, but otherwise CT angiography or normal angiography can tell us that there is abnormal origin. CT angiography is even better in diagnosing coronary artery anomaly other than the normal catheter angiography, because in that we can also see the aorta and the pulmonary artery, which is not possible with catheter angiography. This is the picture of a coronary artery anomaly arising from pulmonary artery and between aorta. So it gets compressed on exertion. It also leads to exertional death. हो सकता है जो जिम्स में डेथ हमने सुनी है उनमें से कुछ हाइपरट्रॉफिक कार्डियोमायोपैथी हो, कुछ कोरोनरी आर्टरी एनोमली हो, कुछ ब्रुगाडा सिंड्रोम हो, कुछ लॉन्ग क्यूटी सिंड्रोम हो, कुछ एआरवीडीज हो. बट हमें तो सबको हमने क्लब कर दिया मायोकार्डियल इंफार्क्शन में, सबको एथेरोस्क्लेरोटिक कोरोनरी आर्टरी डिजीज बना दिया. उसकी प्रिवेंशन में हम लग गए और लोगों ने लाइफस्टाइल चेंज करना शुरू कर दिया. सो पब्लिक में ये अवेयरनेस, हम में सब में अवेयरनेस बहुत जरूरी है. कोरोनरी आर्टरी एनोमली का बड़ा सिंपल सा इलाज है. वी कैन गिव बीटा ब्लॉकर्स की हार्ट उतनी जोर से कॉन्ट्रैक्ट ही ना करे. ऑल्दो स्टेंटिंग एंड सर्जरी कैन इजीली take care of this coronary artery anomaly, and till such thing is done, strenuous activities should be avoided. So अब हम क्या कर सकते हैं? What we should do to prevent this? So ये बड़ा important slide है. अगर कोई भी athletic training start कर रहा है, एक ये भी बड़ा important है. People who have never played in their life, they have started vigorous athletic training above the age of 35, 40 पे start कर रहे हैं, मैराथन दौड़ रहे हैं. So this is a 12 element American Heart Association recommendation for pre-participation cardiovascular screening of competitive athletes. Personal history में exertional chest pain, unexplained syncope, excessive exertional and unexplained dyspnea, prior recognition of heart murmur, elevated systolic blood pressure, family history, premature death, disability from heart disease, specific knowledge of certain cardiac conditions in family members. Physical examination में we should look for heart murmur. We should always palpate the peripheral pulses to exclude aortic coarctation. Marfan syndrome का physical signs हमें rule out करने चाहिए. बड़े सिंपल वो होते हैं कि उसका आर्म अगर आप खुलवा के देखें, आर्म स्पैन अगर उसका हाइट से बड़ा है, so patient is a marfanoid. ब्रेकियल आर्टरी ब्लड प्रेशर हमें लेना चाहिए सिटिंग स्टैंडिंग दोनों में. सो ये 12 एलिमेंट अगर हम स्क्रीनिंग करते हैं, हर एक की करनी चाहिए इफ स्टार्टिंग कॉम्पिटिटिव एथलेटिज्म. नाउ हाउ टू सेव लाइव्स, ये तो हमने कॉजेज समझ लिए एज आईएमए एज एन ऑर्गेनाइजेशन, बट वी शुड नो कि हमें कैसे जान बचानी है. Even in countries like USA with advanced emergency response systems, only 8% of sudden cardiac arrest victims survive out of hospital occurrence. क्या होना चाहिए? सर्वाइवल चेन क्या है? देयर शुड बी अर्ली एक्सेस, देयर शुड बी अर्ली सीपीआर, देयर शुड बी अर्ली डिफिब्रिलेशन एंड देन रेफर टू एडवांस केयर. So we all should know the BLS, ACLS training, and as an organization हमें public में भी इसको disseminate करना चाहिए. How to do proper CPR. So that is very very important. बड़ा अच्छा initiative IMA ने लिया है. We have attended classes of ACLS, BLS, and repeated courses have been done on behest of Indian Medical Association. So this process should be continued, and general public should also be involved in this. Then comes the role of automated external defibrillators. So these give quick shock, they boost survival, बड़े यूजर फ्रेंडली होते हैं, इजी गाइडेंस होती है, एंड पब्लिक एक्सेस भी होता है इनका. इफ यू हैव गॉन अब्रॉड यू मस्ट हैव सीन AEDs implanted, or they are in airports, malls. So how to use them we should all know. We should turn on the AED, follow the visual and audio prompts. वो बोल के बताता है कि ऐसे ऐसे करो. Remove clothing from the chest of the patient, place the electrode pads correctly, ensure that no one is touching that patient, deliver a shock if the AED indicates, because it reads the ECG and it will tell you that it needs a shock. And just after giving shock, continue the CPR immediately after delivering the shock, because if heart rhythm is restored, then we should continue the CPR, breathing, everything should be done. So ये हम सबको करना चाहिए. We all should know, and as an organization we should propagate this also into the general public. एक छोटी सी बात जो मैं I will like everybody to know that sometimes we are doing AED or doing defibrillation. So the most important thing is how to place the pads. I have seen defibrillations failing because the pads are placed so close to each other. So what happens is, बेसिकली इसका मैकेनिज्म क्या है? मैकेनिज्म ये है कि एक साइड से करंट जाएगा दूसरी तरफ, तो पूरा मायोकार्डियम हमने उस करंट के एरिया में लेना है, तभी वो डिफिब्रिलेट होगा. अगर हम पास पास रख देंगे तो स्किन में से करंट ट्रांसफर हो जाएगा. सो जो ये वाला पैड है जो हम कहते हैं कि हमें यहाँ रखना है स्टर्नम पे, वो जितना हम एक्सिला पे रखें, यहाँ पे रखेंगे. अगर पेशेंट बैठ सकता है तो उसकी बैक पे भी रख सकते हैं. उससे क्या होगा कि मायोकार्डियम जो है वो टोटल इसमें आ जाएगा इस करंट के एरिया में और डिफिब्रिलेट होगा. तो ये सब चीज हमें जरूर से आनी चाहिए. जब हम डिफिब्रिलेट कर रहे हैं उस टाइम घबराए भी होते हैं, वी आर इन पैनिक मोड ऑल्सो, द पेशेंट इज डाइंग और वी आर डूइंग in a public place by AED, we should also know that where to place the electrodes. So what is this defibrillation therapy? This is a very important short small 10 seconds video. This the heart is beating like this normally, then it starts having fibrillation, you can see, and then the ICD delivers the, now you can see that it delivers the shock, and then you can see the heart rate normalizes, the walls open normally, and there is restoration of blood flow. So ये क्या होता है? ICD क्या है? ICD is an implantable cardioverter defibrillator. It is a device, पेसमेकर की तरह होता है. एक छोटी सी सर्जरी से आपकी क्लेविकल या पेशेंट की क्लेविकल के नीचे इसको इम्प्लांट कर दिया जाता है. इनमें से एक लीड राइट वेंट्रिकल में जाती है जैसे नॉर्मल पेसमेकर्स की जाती है. सो दिस इज द बैटरी, कैन होता है, इसमें एनर्जी होती है. सो इट इज लाइक कैरिंग ए कार्डियोलॉजिस्ट along with you in your chest. This will keep on reading the ECG, diagnose the ECG, and if shock is indicated, will give it immediately. इसकी प्रोग्रामिंग आप इसको बिना खोले बिना इस पे कर सकते हो. ब्लूटूथ प्रोग्रामर आते हैं, एंड इट कैन डायग्नोज द ECG सो करेक्टली दैट ये VT वेंट्रिकुलर टेकिकार्डिया एंड VF में डिफरेंशिएट कर सकता है. इट कैन गिव एप्रोप्रिएट थेरेपी फॉर वेंट्रिकुलर टेकिकार्डिया विच इज नोन एज एंटी टेकिकार्डिया पेसिंग. ATP देता है पहले, ATP से रिवर्ट ना हो, then it gives the shock, and then it gives incremental shock up to 40 joule तक ये shock दे सकता है. Now somebody may ask कि we give a shock of around 100 joules जब हम externally देते हैं, but because this is intracardiac, even an 8 joule of shock is also sufficient. Patient feels the shock, but it is just a little discomfort to him, and his life is saved. सो ये हम किन में लगा सकते हैं? एज ए प्राइमरी प्रिवेंशन लगा सकते हैं. सो लिस्ट ऑफ इंडिकेशंस हैं उन पेशेंट्स को जिनको हार्ट अटैक हो चुका है और या किसी भी वजह से उनका इजेक्शन फ्रैक्शन लेस देन 35 है, उनमें दिस has to be implanted as per the latest guidelines to prevent sudden cardiac death. Primary prevention is very low in India because the benefit is modest, and there is a out of pocket expense. It is a costly thing to have it, cost around 5 to 6 lakhs, but we can risk stratify all those patients who have suffered heart attack. So there is an algorithm which we can follow. So what is the ejection fraction? There should be a waiting period of 90 days post revascularization. किसी की एंजियोप्लास्टी या बाईपास हुआ है या एमआई हुआ है, हम 90 डेज तक वेट करें, अगर उसके बाद भी उनका इजेक्शन फ्रैक्शन लेस देन 35 है, हम रीअसेस करें, तो he should need an ICD, and this is can be a life savior, because more than half of the sudden cardiac victims are having ejection fraction even more than 30, उनके उनमें भी ऐसा डेथ्स होती है. So this I am talking about the general whole of the population. जो हमारा टॉपिक था young patients में, उनमें I have told that the channelopathies, and those are more important causes as compared to post MI, post CABG patients. ये तो है ही atherosclerotic coronary disease के साथ, but we should be aware of the channelopathies, the hypertrophic cardiomyopathies, ARVDs, which can be easily diagnosed by a simple ECG and echo. So what is the road ahead as an organization for us? First, we should make our members aware of the causes, कि ये अलग से cause भी होते हैं, हर चीज heart attack नहीं होती. यंग लोगों में causes usually different होते हैं. This is a very good initiative taken by the IMA. I absolutely salute कि इस तरह की अवेयरनेस के लिए हमने एफर्ट किया, बट हमें जनरल पब्लिक में भी करना है. BLS ट्रेनिंग एटलीस्ट शुड बी फॉर ऑल जनरल पब्लिक, जितना तक हम जा सकें या गवर्नमेंट से हम रिकमेंड कर सकें. एंड वी शुड request the government to have AEDs at public places and frequent training sessions of those AEDs and maintenance. कोई भी एक्सरसाइज के लिए स्टार्ट करता है, वो हम में से भी कोई हो सकता है, हमारा कोई रिलेटिव हो सकता है. We should have an extensive pre-exercise screening, especially if he's starting for the first time. Otherwise also, if somebody is not going for exercise, a routine evaluation by a simple test like ECG and echo or a treadmill can, I think, unmask many patients who have this wrong potential of having sudden cardiac death in future. If we diagnose them in time, we can easily save those lives. I thank everyone for listening carefully, and if there are any questions, I would like to answer them.
Thank you, Dr. Sanjeev, for a masterly presentation. We know that we have to differentiate between sudden cardiac death and heart attacks in young, and you have correctly highlighted this differentiation. For sudden cardiac death, definitely we have to identify the patients who are at the risk of sudden cardiac deaths by simple ECG and many times with the simple echocardiography, both of which are non-invasive. And at the level of IMA and at the level of policymakers, definitely we need to go for basic training of general public, more of general public to train them for BLS training, like simple cardiac massage and simple mouth-to-mouth respiration. And AEDs can be placed at the public places to avoid such important and such lives which are very, very crucial to the society. So these two things are really mandatory, and at the level of IMA, we must pressurize, or we must recommend to the government to do this BLS training mandatory for the schools. Like in our school in Rewari, we conducted this BLS training not only for our students and teachers, but also for our support staff, like bus drivers, like our other support staff who are actively involved in carrying the students to the school. So we conducted this activity 2 times in last 4-5 years, and definitely if such activities are conducted on day-to-day basis, then probably it is going to be beneficial for the general public also. And as far as these sudden cardiac deaths are concerned, these two activities are probably going to be the most important, because we have got only 2 minutes to act, 2 or 3 minutes to act, because after 2 or 3 minutes there will be basically setting of anoxic encephalopathy, And if we are delayed by more than 3 minutes, then probably the patient will not be able to survive. So this is very important, and I would request Dr. Sanjeev Chaudhary to please highlight some important risk factors and the preventive strategies for for heart attacks in young people also, because it is again seen in our clinical practice that the patients aging only 23 years, 24 years, 30 years are coming to us with extensive heart attacks, and these heart attacks are really more devastating, and they have increased mortality because of certain risk factors which are present in young only. So I would like to ask Dr. Sanjeev Chaudhary to highlight on these 2 points also.
Sir, you have very rightly pointed out that there are patients now coming at younger age with atherosclerotic coronary artery disease. Basically, we all know the traditional risk factors, they work in younger population also, like smoking. There have been a lot of debate about the COVID vaccination leading on to heart attacks, but we have seen that there is no data to suggest that. But yes, definitely patients have suffered myocarditis also and inflammatory disease in the heart, which may have progressed or may be now at a subclinical level, which is leading on to atherosclerotic coronary artery disease. Other than that, I would like to highlight that there are some newer risk factors which are now you routinely diagnosed, and people do extended lipid profiles. I would like to name about homocysteine, lipoprotein little a, and these also should be measured like a normal lipid profile, although there is no medicine at present for lipoprotein little a, but a lot of research is going on, and 2 3 are now in the pipeline. Within next 2 years we will have a medicine which can be commercially used to decrease lipoprotein little a. For homocysteine, which increases the viscosity of the heart and causes clotting, that also we can easily investigate and find out by the lab test. Then there are some genetic abnormalities like protein C and protein S deficiency, which can also cause increased clotting of the blood. Then there is factor 5 laden genetic mutation. So there are so many things which can cause atherosclerotic coronary artery disease and also clot formation. So young patients, I think that is also very important. So we should, other than all the normal risk factors like exercise, stopping smoking, taking care of diabetes, taking care of this recreational use of drugs, we should also try to investigate the young patients who, for secondary prevention, those who have suffered from one attack, for second attack, we should also investigate this homocysteine and everything.
Dr. Sanjeev, I would like to highlight some other factors also, like in younger population, there is increased incidence of substance abuse.
Yeah, recreational drugs.
There is also increased prevalence of smoking and stress. Emotional and physical stress is also playing havoc on our youth, and probably they are also the cause of increased incidence of these sudden heart attacks also.
Definitely.
And one more thing, like familial hyperlipidemias, they are again an important factor. And recently we have very good drugs in the form of PCSK9 inhibitors,
yes,
which can be given in such patients to decrease the LDL, very high LDL levels. So these can be really life-saving. If we can identify these patients, then probably it is going to be life-saving for our patients. If anybody else is having any question, then he can unmute, he or she can unmute himself or herself and ask directly from Dr. Sanjeev, or they can put your questions in the chat box. I will ask them on their behalf from Dr. Sanjeev.
Please suggest for cystatin C level. Cystatin C level.
Cystatin C level, I'm not aware. I think it's more for diabetes, because it is a cystatin C is increased in diabetes patients. I don't know about the cardiac risk factor of cystatin C. Sorry.
When some literature recommended that this enzyme slash is regarding to CKD or early detection of CAD.
So I'm not aware. I'll study and then I can answer that.
Okay, sir.
Good evening, Dr. Vashish, sir.
Good evening.
चलो बंद कर दे कुछ
Lot of disturbance, admin.
I would congratulate Dr. Sanjeev Chaudhary for such a nice and lucid presentation, and I take pride. Dr. Sanjeev is my class fellow and my
Thank you, Samir. Thank
Next,
you.
next will Dr. Sanjeev, I would like to share one experience. During our medical college days, there used to be a class fellow. I don't know whether I should know him or not, but he probably had a sudden cardiac death. And he was complaining of slight discomfort in the chest for the last few days, couple of days. And he went to the senior consultant, and he carried out echocardiography and ECG, and that was normal. And probably he might be having anomalous coronary arteries.
Dr. Samir, you are not properly audible. Can you come close to the mic?
Okay, sir. Am I audible now?
Yeah, a bit better. A bit better.
Better. So, can you comment, Dr. Sanjeev?
Yeah,
What could be the cause
that was a very tragic incident. It is still etched on all of our minds. I think he came outside from the common room just like that after watching a match, and he just fell down and we could not do anything. So, I mean, now I can say must be one of those cases. It's very difficult to say retrospectively what actually happened, but yes, coronary artery anomaly is one of.
Thank you.
Hello? 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 Yeah, please.
Yes, yes.
Yes, sir.
Please. So there is some information I sent in the message group. And can you go through this and explain the regarding C16 level?
Dr. Sanjeev, your view on cystatin C.
सर एक ना हमारा वाइवा हुआ था एक बारी, तो किसी ने कहा जी ये इस हर्निया के बारे में बताओ, कहना जी मैं पढ़ के नहीं आया, कह जी अब इसके कॉन्ट्राइंडिकेशन बताओ, क्या मैं पढ़ के नहीं आया, क्या सर्जरी कैसे करेंगे इसकी, क्या जी मैं पढ़ के नहीं आया, क्या अभी बताओ इसकी कॉम्प्लिकेशन क्या होती है, क्या मैं पढ़ के नहीं आया। सर मैंने कहा ना सिस्टेटिन सी के बारे में नहीं पढ़ के आया मैं।
ठीक 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 है डॉक्टर संजीव। Let us go to some other question. Dr. Vashisht, your question was basically.
No, not basically, not acidically. I had not raised any question. I was not allowed to speak anyway. Very good evening to all. This was a good and impactful lecture, and thanks to IMA leadership and to Pawan also for instituting such a good academic fiesta on every Thursday. My only question to Sanjeev is that on WhatsApp University, we come across very frequent messages that if you are alone and if you feel that you might be having some cardiac event, start coughing violently, because that will push some of the blood in your heart because of squeezing of the chest cavity. And what is the reality and truth behind this WhatsApp University message?
Sir, there is no scientific evidence behind this. I mean, there is no scientific study to prove that whether it helps or not. I mean, this is just an hypothesis which has to be proven or disproven by proper study. Only then we can say whether it is recommended or not.
Thank you. Thank you.
डॉक्टर संजीव, आजकल एलडीएल कोलेस्ट्रॉल की एडल्ट्स के लिए एलडीएल कोलेस्ट्रॉल की इंपॉर्टेंस है या खत्म हो गई?
नहीं सर, पूरी इंपॉर्टेंस है। एलडीएल कोलेस्ट्रॉल इज द बैड कोलेस्ट्रॉल, so that actually promotes it is a harbinger of coronary artery disease. ऐसा तो नहीं है सर, बहुत इंपॉर्टेंट है।
तो लेटेस्ट सर कहते हैं कि भी उसकी कोई आजकल भी कई लोगों से मैंने सुना कि एलडीएल की कोई इंपॉर्टेंस नहीं है जी।
सर आप मुझे फोन कर लिया करो कोई ऐसी चीज सुनो तो। पर वैसे मैं आपको बता रहा हूँ सर कि एलडीएल का ना सिर्फ इतनी बात है सर कि जो टारगेट लेवल है ना, जो लैब्स पब्लिश कर देती हैं वो बड़े एरोनियस हैं। सो टारगेट्स जो हैं, मैं आपको 2 मिनट में ब्रीफ में बता देता हूँ सर। दैट डिपेंड्स अपॉन द कंडीशन एंड रिस्क फैक्टर ऑफ द पेशेंट। लाइक फॉर एग्जाम्पल, अगर आपको कोई रिस्क फैक्टर नहीं है, आपने सुना होगा लोग कह रहे हैं कोलेस्ट्रॉल का कोई फर्क नहीं पड़ता, उन लोगों के लिए है कि आपको कोई रिस्क फैक्टर नहीं है, कोई फैमिली हिस्ट्री नहीं है, कोई डिजीज नहीं है, तो आपका जो एलडीएल है वो 130 to 160 भी ओके है। देयर इज नो नीड टू ट्रीट दैट। अगर आपको एमआई हो चुका है, आप सेकेंडरी प्रिवेंशन में जा रहे हो, तो आपका जो एलडीएल टारगेट है वो लेस देन 70 है, इवन लेस देन 55 है। सो डिफरेंस बहुत है सर इन दोनों में। जबकि लैब्स पब्लिश कर देती हैं कि 100 से नीचे नॉर्मल और 100 के ऊपर एबनॉर्मल। तो इट ऑल डिपेंड्स कि पेशेंट का रिस्क प्रोफाइल क्या है। आपको 2 रिस्क फैक्टर हैं, आपका टारगेट 100 है, सो इस तरह से जिसको आप हो क्या रहा है, इसका थोड़ा ऑपोजिट इफेक्ट भी हो रहा है। जिनको कोई रिस्क फैक्टर नहीं है, कुछ भी नहीं है, उनका एलडीएल 110 आ गया और वो ट्रीटमेंट के लिए भाग रहे हैं, वो भी गलत है। इट्स नॉट नीडेड। सो इन दोज केसेस एलडीएल हैज गॉट नो वैल्यू, बट अदरवाइज एलडीएल इज अ वेरी इंपॉर्टेंट मार्कर ऑफ कोरोनरी डिजीज एज अ रिस्क फैक्टर।
ठीक है, सब ठीक है।
Is there any problem if we, Dr. Sanjeev, Dr. Punia here?
जी
Is there
सर।
any problem if we keep our LDL, diet LDL around 70 to 80?
Sir, if
हाँ
you
जी, हाँ
keep it without medication, I think it's an excellent thing. But if you take medicines for it, then you are trading off between the side effects of the medicine and not so known benefit of reducing it if you are not have any risk factor. So इधर अब थोड़े से वो हैं सर, रिस्क साइड इफेक्ट्स हैं, और उधर बहुत ज्यादा बेनिफिट नहीं है। बट अगर आप बिना मेडिसिन के कर रहे हो सर, देन हैट्स ऑफ टू यू। आई थिंक दैट्स एक्सीलेंट टू डू इट।
Good. Thank you.
I also try to keep it below around 70, but with the help of torvastatin. Family history is positive. My brother had cardiac surgery at the age of 65. I am just 67 and a half.
So then the actual target is 100 for you if you haven't suffered it. 70 say below is for those who have already suffered an heart attack. But that's okay, sir. That's good if you are
Okay, okay.
keeping it.
Thank
ठीक है,
you,
thank you.
Jeev. It was very nice presentation. And मैं जहाँ तक समझता हूँ, early suspicion in the mind of the treating physician, and then just ruling out the different things, having risk factors, probably investigating him properly. That is the thing. And definitely all these things like smoking and other things, those who are risk factors as far as non-communicable, all the non-communicable disease concerned, they should be taken care of. And this is one good thing which you had told, that if somebody is starting vigorous exercise after the age of 35 years, they should be screened properly. And I think this message, because many of our colleagues, they are starting marathon and other exercises at 40, 45, 50 year of age. So this message must go to the society that if somebody is doing that, it is better that he should have a proper cardiac screen. And so that is very good. The few messages which we must give to our fraternity as well as to the society also. And BLS is definitely one thing which each and every citizen must know. But at least those who are in the public life, like all the police persons, traffic police persons, drivers, conductors, they must be during their training time, they must be taught this BLS definitely. So, and I congratulate you. That's probably first time we crossed the 50 marks. वैसे तो हम हरियाणियों को डायरेक्ट पर्सन से ही ज्ञान मिला है, but still I'll request each and everybody present in this meeting, whenever there is a next meeting, please circulate that message in your different groups also, local groups and your friends groups, so that more and more people can join, and speaker also feel good, and the organizer Dr. Pawan Goyal also feel good. So, and definitely once we listen, we learn something new. So thank you, Dr. Sanjeev. Thank you very much for your hard work and such a lucid presentation. Thank you so much.
थैंक यू सर। जो नॉर्मल हार्ट अटैक्स, एथेरोस्क्लेरोटिक कोरोनरी आर्टरी डिजीज है, उस पे कई लोगों के मुझे सवालों से लगा कि पीपल हैव मेनी क्वेश्चंस अबाउट देम। So whenever you permit, we can have a session on that, because that actually concerns us at this age. So this was about young deaths, so I concentrated more on that. Thank you, sir.
I think Dr. Pawan Goyal will take a note of it, and
Sure,
then
sure.
when we had some time, definitely we will put a session for this also.
Yes, sir. In coming months, we definitely will have a session on this also.
Thank you, sir.
सर एक CPR का भी सर सेशन अगर हो जाए तो अच्छा है सर। हमने अटेंड किया है BLS पर, काफी समय हो गया है।
वो फिजिकल में करेंगे सर, वो फिजिकल करेंगे। I'll arrange the things for IMA members.
ठीक है
Probably
सर।
we will do a session for BLS as well as ACLS.
Great, sir. Great.
I am a trained ACLS trainer also.
Good, Dr. Pawan Goyal. Do we have some mannequins also for the training purpose?
We will arrange mannequins. It is available with some pharma companies, and we will probably do it at the level of IIM Haryana physically.
Then it will be very nice.
Yeah, we'll do it. We'll do
So
it.
you
Sir, एक
talk to
last
that
चीज-
pharma company, and
Yeah.
Dr. Sanjeev must also be knowing
Yes, sir.
that who is supplying these mannequins,
Yes, yes.
so that we can at
Yes.
different places we can have these sessions for our own members, and like our Indian Academy of Pediatrics, we had a completely separate this BLS cell, and there we are doing program for the public and for these police personnels and others also. So that also we can try. But definitely it will be a good start if we can arrange some BLS session for our own members and for the public at different places. Thank
But
you.
we did this BLS with mannequin only in our school, and probably we can arrange it at different zones in IMA Haryana.
I think Dr. Pawan, you and Dr. Sanjeev and few other colleagues, if you can take up this thing, and if we can do some certain sessions, so it will be of great help for our own colleagues and for the public also.
Yes,
Yes.
yes. I'll take the help of Dr. Sanjeev. Definitely, we will plan.
सर मैं एक चीज और कहना चाहूंगा, डॉक्टर पवन गोयल हमारे सीनियर थे, हमें को इन्होंने मेडिसिन पढ़ाई है, मैंने इनकी खूब क्लासेस अटेंड की हैं, इनकी क्लास बड़ी पॉपुलर होती थी, मैं आज भी इनसे सीखता हूँ और पहले भी पढ़ा हूँ. ही इज माय टीचर. थैंक यू.
अरे नहीं डियर, नहीं है.
नहीं सर, काफी
we are all learners. We are all learners, and we are learning from each other. We share our knowledge, and knowledge sharing is the real thing.
नहीं सर, इस बात को तो रोहतक की काफी लड़कियां भी कहती हैं सर.
तो सर एक जो है एक क्वालिटी काउंसिल ऑफ इंडिया NABH जो है वो एक प्रोग्राम करने जा रहा है कल ऑनलाइन. तो अगर किसी भी हमारे कोलीग की कोई भी NABH रिलेटेड क्वेरी है, किस तरह से अपने हॉस्पिटल को NABH सर्टिफाई कराना है या NABH एक्रेडिट कराना है, तो उसके लिए उनका एक ऑनलाइन सेशन है. तो उसकी डिटेल्स मैं अपने उस पर डालूंगा IMA ग्रुप पे. तो those colleagues who are interested in attending that session, probably they can attend it. And now I will request Dr. Mohan Rastogi, who is director of IMA CJP Haryana, to post his message of thanks to those who have attended the program, and to our learned speaker, Dr. Sanjeev Chaudhary.
Thank you, sir. Thanks, President sir, Dr. P.JAIN sir, and of course, dear Chaudhary, who has really, put all the points in a very concise manner and to the understanding of all. So, and again, in the words of Dr. Jain, that today the attendance has increased beyond 50. So I think that is a remarkable thing, and we think that the attendance further increase in the future also for this kind of the program, and for this Dr. Goyal needs applaud for that. So thank you very much, dear Sanjeev, and all the attendees. Thank you very much.
Thank you, dear friends, and good night.
Thank you.
Good night.
I'll be sharing that link for NABH program.
Yes, please.
Thank you.
Thank you. Good night.
Good night.
Good night.
Right.
Good night. Jai Hind.
Good night, sir. Good night. Good night.
Right, Sanjeev.
Bye, sir.